Welcome to Health Matters, where we explore key topics from a primary care perspective. I'm your host, Dr. Sheylan Spencer. Here at Vandalia Health, we are passionate about bridging the gap between primary care and specialty medicine, ensuring that complex medical topics are accessible and understandable for healthcare providers and patients alike. In each episode, we'll dive deep into the latest advancements, best practices, and critical insights to help improve patient care. Thank you for joining me on this journey toward better health. Welcome back to Health Matters. I'm your host, Dr. Sheylan Spencer. Today on Health Matters, we're excited to be joined by Dr. Madonna Gribble, a proud lifelong West Virginian. Dr. Gribble completed her medical training at the West Virginia School of Osteopathic Medicine and went on to finish her family medicine residency right here at Charleston Area Medical Center. She has a real passion for academic medicine and has been serving as an associate professor in the CAMC Family Medicine Department for the past 3 years. Alongside her teaching, she continues to care for patients across West Virginia, something she's deeply committed to. We're thrilled to have her on the podcast today.
Wow, thanks so much for having me today, Shay. I'm excited to talk through some of these scenarios. Diabetes management has evolved so much in a very short time, and I think it's great to put the evidence into some real-world context.
So, Dr. Gribble, before we dive into the medical side of things, when you're not teaching or caring for patients in general, what do you like to do in your spare time?
I think that's a very loaded question, Shay. But I do enjoy a lot of special interests and hobbies outside of medicine. I'd say what I go to most to recharge my batteries is just getting outdoors, whether it's hiking, backpacking, camping. Those are kind of my go-to to keep myself grounded.
Off the rip, what is the favorite place you've been to?
Oh, that's super duper hard, but I would say the most awe-inspiring place I've ever been was Crater Lake.
Oh my God, where is that?
That is
nobody's familiar with that.
It's in southeast Oregon, I think.
Not close to Buchanan.
Oh, yeah, wrong side of the country, friend.
Southeast Oregon, that is beautiful.
Yeah.
Definitely something Amber would want to go to one day.
Yeah.
So if it's okay with you, we'll just kind of walk through some of these real-world clinical vignettes. Some of these might have been patients actually that we've seen upstairs in the family medicine clinic. But I think it's important really just to dig deep today and talk about things that primary care physicians see on a daily basis, and that's diabetes management.
Mm-hmm. Absolutely. I'm excited to get started.
Yeah. So we have Mr. Turner. Mr. Turner, he's a 54-year-old gentleman. He has a past medical history of hypertension. I think he's got a little bit of hyperlipidemia. And, of course, he's a type 2 diabetic. Today, he's presenting to the family medicine clinic for a follow-up regarding his type 2 diabetes. Overall, he says, really, I've not had any change in symptoms. He's denying any polyuria, says he's not had any hypoglycemic episodes. In regards to his BMI is 33. Previous A1C was 8.6%, which looks like it has increased from 7.9% around 4 months ago. In terms of medication, it looks like he's only on metformin, 1,000 milligrams, and he takes it BID. Socially, he works at night shift, says he consumes irregular meals and has low physical activity. In terms of his vitals, he's vitally stable. Physical exam's pretty darn unremarkable. He does mention to you before you even start talking about pharmacological therapy, he says, hey, I want to avoid insulin if that's possible. So, Dr. Gribble, when you have a patient like Mr. Turner, notice that his A1C is worsening. I believe it was 7.9 to 8.6%. Despite metformin, what are some of the things that you start thinking about next in terms of management for him?
Yeah, you weren't kidding about this being like some of the folks that we see upstairs in our daily practice, were you? But one of the first things I like to assess is medication adherence, including lifestyle barriers and whether anything has shifted around in their life, new stressors, job changes, even sleep disruption. Once I'm confident metformin has been maximized and tolerated, ADA guidelines suggest adding either a second agent based on patient-specific factors, for example, like cardiovascular disease, hypoglycemic risk, weight goals, cost, etc. In someone like Mr. Turner who's got obesity, we want to avoid insulin. GLP receptor agonists can be a good option, as well as an SGLT2 inhibitor.
You mentioned GLP-1s or an SGLT2s. What makes you choose one or the other as a next step in therapy for Mr. Turner?
I think it depends on the goals for the patient. So, for example, if weight loss is a top priority, or if they struggle with overeating, a GLP-1 receptor agonist offers superior weight management as well as A1C reduction. If a patient has things like heart failure with preserved ejection fraction or reduced ejection fraction or even CKD, SGLT2 inhibitors offer strong renal and cardiovascular benefits. Both classes have low hypoglycemic risk, which aligns with ADA recommendations. Ultimately, it's a blend of clinical benefit and practical issues like insurance coverage and patient comfort with injections.
Wow, such practical advice. So counseling on things like injections. What else are you counseling on in terms of like side effect profiles, and how are you helping patients kind of navigate this?
Yeah, this is a great question. It's also kind of a loaded question. Ultimately, tolerability is going to determine whether these medications work in the long term. So starting with the GLP receptor agonists, prior to initiating this with a patient, we always make sure patients have never had a personal or a family history of medullary thyroid carcinoma, MEN2. It's rare but important to ask about. I also avoid them in patients with a history of severe gastroparesis because delayed gastric emptying can significantly worsen symptoms and ultimately tolerability. If someone has had a recurrent pancreatitis, we proceed cautiously or choose another agent. However, there's actually some new evidence coming out showing that pancreatitis might not be directly correlated with these GLP-1s.
Thanks for that.
On the other hand, with our SGLT2 inhibitors, they're contraindicated in patients with significantly reduced kidney function. Most agents can be used down to a GFR of 30, but someone is well below that, it might not be safe. I also avoid them in patients with active, recurrent, like genitourinary infections, frequent UTIs, or those at risk for volume depletion, like those with orthostatic hypotension. Also important to pause and think about in patients with a history of DKA, due to the risk of patients developing euglycemic DKA. So ultimately, while both classes are excellent for many patients, a quick review of these contraindications can help us pick the most effective option.
Thanks for that feast of learning. So what I'm hearing is for GLP-1 receptor agonists, you want to know about previous history of medullary thyroid carcinoma or MEN2, severe pancreatitis, severe gastroparesis. For the SGLT2s, GFR less than 30, they're at increased risk for GU infections, and then orthostatic hypotension, or if they're at risk for volume depletion. So thanks for that. So what are some of the most common side effects that you do see in everyday clinical practice?
Yeah, this is a really great question too, Dr. Spencer. Kind of boils down to, for a lot of folks, they're super well tolerated. However, some may experience some of the more mild and most common side effects. Starting with our GLP-1 receptor agonist, the most common issue is GI upset, as we alluded to earlier. These can include nausea, early satiety, sometimes even reflux and constipation. I always emphasize that these symptoms are typically dose-dependent and improve over a few weeks. Slow titration, I feel, is the key. I coach patients to eat smaller, more frequent meals, avoid high-fat foods initially, and stop eating when they're comfortably full. If nausea still persists, it's okay to pause the dose escalation. Many patients do well once they adjust. On the flip side, for our SGLT2 inhibitors, we previously talked about, the biggest side effect is the GU symptoms. It's important to think about good hygiene and early recognition with our patients. Rarely we worry about euglycemic DKA, so I tell patients if they're feeling nauseated or just not able to eat to call us.
Yeah, that's super great advice. Earlier you had mentioned just investigating barriers in patients' health. What are some of the barriers that you can identify for Mr. Turner?
I think that you had mentioned earlier that Mr. Turner works third shift. The night shift population are uniquely vulnerable because of the shift in the circadian rhythm, which can worsen insulin resistance. Some practical things that we could implement would be consistent timing of his meals whenever possible. Not only consistent meals, but protein-rich meals, which can help with his basal glucose and decreasing glucose spikes. You mentioned that he didn't get much physical activity. Starting with a short, achievable exercise goal like a 10-minute walking break would be reasonable. And then lastly, trying our best to help him work on sleep hygiene. This has a big impact on glucose, bigger than many patients realize. Small, sustainable changes are more important than perfect.
Such practical advice, Dr. Gribble. You talked about how improving sleep hygiene and then eating smaller, more frequent meals and making sure that they're protein rich can certainly help with those glucose spikes. So we've talked about treatment. You've even addressed barriers. So let's talk about making sure we aren't missing any of those nasty complications that can happen. Mr. Turner, he's 54 years old. A1C certainly creeping up. Looks like he's been overdue for follow-up. What screenings should we be prioritizing right now?
Yeah, this is another great point. Ultimately, because treatment only goes so far if we're not monitoring complications early. And I think it's also important to remind our patients that complications of diabetes are inevitable. For Mr. Turner, I'd like to focus on the full set of ADA recommended screenings. We want our patients to have a dilated retinal annual exam, if possible. We need to be screening for nephropathy with a yearly urine albumin to creatinine ratio. Early nephropathy is silent, and this could let us know whether an SGLT2 inhibitor may provide some renal protection. I also like to do a quick monofilament exam at least once a year. I usually pair this with checking for skin breakdown or any other foot deformities that could be pre-ulcerative lesions. Lifestyle and work factors, like being on your feet in night shift in Mr. Turner's case, make this even more important. And let's also not forget that diabetes is a cardiovascular disease equivalent. I'd like to make sure that we have tight control of Mr. Turner's blood pressure. Ideally, we'd want him less than 130 over 80. Of course, using ACEs and ARBs, we should make sure that he's on the appropriate statin and smoking cessation if needed. ADA also emphasizes the importance of annual influenza vaccine along with pneumococcal vaccinations. These often get overlooked during our short visits.
Such good advice, making sure that your patient's on the ACE or ARB, screening for that early signs of diabetic nephropathy with the urine microalbumin to creatinine ratio, the moderate intensity statin, but of course if they have ASC VD risk factors, we want them on the high intensity, getting our eye exam and our feet examined. So Mr. Turner, he is so thankful for the care that you provided him that he says that he's going to refer his neighbor, Miss Evelyn Harris, to you. So Miss Evelyn Harris is a 67-year-old female who's presenting today to Establish Care. She has a history of longstanding type 2 diabetes, says that she was diagnosed around 18 years ago. She also has a history of stage 3B CKD, hypertension, diabetic neuropathy, and coronary disease. She presents today to Establish Care, currently on metformin 1,000 milligrams, which she takes twice a day. She was continued on this before the progression of her CKD, so you're okay with that. Glargine 20 units at night, as well as lisinopril 20 milligrams and Crestor 20 milligrams. Her last A1C was 7.9%. She does mention that she's had occasional fasting, hypoglycemia, and some fatigue, but she denies chest pain. So Dr. Gribble, Mrs. Harris is fundamentally different from her first patient, Mr. Turner. She's a little bit older, has established diabetes. She is stage 3B CKD, and she has a little bit of cardiovascular disease. So how are you approaching glycemic management in someone like Ms. Harris?
Yeah, so in patients like Ms. Harris, ADA guidelines emphasize that the priority shifts from more aggressive A1C lowering to avoiding hypoglycemia and protecting cardiac and kidney outcomes. Her A1C being at 7.9% is actually very reasonable for her age and her comorbidities. She's having fasting lows in the 70s, which isn't too surprising. Older adults with CKD have reduced insulin clearance, so hypoglycemia becomes more of a real risk. I'd absolutely reduce her basal insulin dose, sometimes by 10 to even 20%, or consider de-intensifying farther her A1C if she can tolerate it. This is a classic scenario where less insulin often means better safety without sacrificing glycemic control.
So making sure our patients are not getting hypoglycemic. For someone like her GFR is 40. Are you okay with something like Farxiga or Jardiance?
Yeah, absolutely. So the SGLT2 inhibitors are still recommended here. For CKD with albuminuria or reduced GFR, ADA and KDIGO both, their guidelines strongly suggest and support SGLT2 inhibitors for kidney and cardiovascular protection. They may not lower A1C at this stage, but the renal and heart benefits remain still very powerful.
So not to catch you off guard, Dr. Gribble, but let's switch gears a little bit. Let's talk about diabetic neuropathy. Ms. Harris comes to you. She's already been diagnosed, but how are patients typically presenting when neuropathy's first developing?
Yeah, unfortunately, most patients will present later in the process than we'd like. Early diabetic neuropathy is subtle and often goes unnoticed. The classic presentation is what we describe as distal symmetric polyneuropathy, what we call that stocking and glove distribution. Patients typically describe a tingling, burning, pins and needles, kind of like 1,000 bee stings type of feeling. Numbness that starts in the toes and slowly creeps upwards. Patients might also say that they have like a sharp shooting pain at night, that so much so that even the sheets touching their feet are intolerable. That's usually how we know what we're dealing with.
The classic board description, a stocking and glove appearance. It seems like you described to our listeners how to identify diabetic neuropathy, but how are you approaching treatment?
Yeah, I like to break treatment down kind of into 3 pillars. And this because medication alone is not the only answer. Firstly, I like to focus on glycemic control. We know we can slow the progression with better glucose control, especially in those earlier stages of neuropathy. I always counsel on daily foot checks and wearing proper footwear because later stages they might not be able to feel any injury. When it comes to the pharmacological treatment, we have a few first-line options. ADA and the AAFP guidelines recommend starting with one of the 3 first-line meds, which are duloxetine, Lyrica, and gabapentin. Cymbalta can be great for patients with comorbid mood disorders and even chronic pain. Lyrica is well tolerated but sometimes limited by sedation. Gabapentin sometimes has similar side effects but is still widely used as well. I'll usually tailor the medication to the patient's comorbidities, whether they have sleep issues, anxiety, or renal function decrease as well. Second-line agents include TCAs like nortriptyline, effective but limited by the anticholinergic effects, especially in our older adults.
It's extremely helpful. So what I'm hearing from you is tight glycemic control helps prevent progression. And whenever it comes to treatments, we should be thinking things like the SNRIs, like Cymbalta, versus the gabapentinoids. And of course, making sure that we're counseling on the daily foot checks to get ahead of those diabetic ulcerations, like you mentioned.
Absolutely.
Seems like the word has just gotten around, Dr. Gribble, gotten around Charleston, that you were taking excellent care of these diabetic patients. Such great care that Mrs. Harris has actually referred another friend to you. We have Mrs. Daniels. She's a 63-year-old female, has a 12-year history of type 2 diabetes. Her baseline control has always been modest, A1C ranging anywhere from 7.8 to 8.4%. She's never required insulin. She's currently on maximized metformin. She's on Farxiga, and she's also been on Ozempic. I think she's been stuck at around 1 milligram because she couldn't tolerate that 2 milligram dose. Over the past 6 months, she has noticed polydipsia as well as polyuria. She's also had an unintentional 8-pound weight loss. Seems like she's had some blurry vision in the evenings, specifically after dinner. She denies any abdominal pain, no vomiting, or any other signs of acute illness. You do a POC glucose today, and her A1C is 10.6%, which is up from around 8.2% a year ago. You also wanted to see what her sugar was in the clinic today, and it looks like the random glucose was 348. So aside from that, her BNP is unremarkable. There is a little bit of mild hyponatremia, which it corrects for glucose. She has no gap. Her GFR is 71, and LFTs are normal. She tells you, I've always hoped to avoid insulin, but I can't seem to get this under control anymore. At what point would you consider insulin initiation in a patient like Mrs. Daniels? Are there any clinical or laboratory thresholds that kind of push you towards that?
Yeah, this one is another one of those super loaded questions because we always hear about these patients who are well controlled and they like to avoid insulin, and then all of a sudden things are just spiraling and they have a hard time reeling it back in. And feel free to correct me anywhere about this, but I do believe the ADA guidelines mention insulin should be at least considered if A1C is greater than 10. especially if you have symptomatic hyperglycemia like our lady Miss Daniels does here with her blurry vision after dinner, or evidence of ongoing catabolism such as weight loss, ketonuria, etc. In this case, Miss Daniel meets multiples of these criteria. Her A1C is 10.6. Her random glucose was pretty elevated at 348. She also has symptomatic hyperglycemia and that unintentional weight loss. This very well may be a presentation of LADA, what we call latent autoimmune diabetes in adults. Patients typically present with an unexpected weight loss, require insulin earlier than expected, or have a low BMI.
You mentioned LADA. Is there a specific way that you can test for that, or what do primary care physicians need to know?
Yeah, of course. You'd want to start by testing for insulin-specific autoantibodies like GAD65, IA2, zinc transporter 8, and fasting C-peptide.
Thanks for that wealth of knowledge. So essentially what you're saying is we should consider LADA in our adult patients who present kind of like Miss Daniels with unexpected weight loss, derangements in glycemic control, and a low BMI.
Yep, you got it.
Shifting gears a little bit, let's say that we went ahead and made the decision to go ahead and start insulin. Are you using basal insulin? Are you using basal bolus insulin? Kind of walk me through that.
Yeah, so when we have patients transitioning from strictly oral therapy and moving into the insulin category, usually basal bolus is reserved for folks with an A1C of 10 to 11 with severe hyperglycemic plus symptomatic postprandial numbers. Also, when fasting and postprandial values both require control, or if patients are suspected to be severely insulin deficient. Given that Miss Daniels is symptomatic but still functioning outpatient and has no acidosis, a basal first strategy is pretty guideline concordant.
Dr. Gribble, this might be a crazy question, but would you continue her current medications once you start her on long-acting, or is there any specific medications you would want to stop?
Yeah, this is a great question, and if I'm recalling correctly, Miss Daniels was on metformin, also had an appropriate GFR, so I'd definitely continue this one. We know that metformin increases insulin sensitivity and reduces insulin requirements. She was also on an SGLT2 inhibitor, which provides cardiovascular benefit and even renal protection, independent of its glycemic effects, so I'd continue this one as well. She was also on a GLP-1 receptor agonist, which we could theoretically continue given the cardiovascular benefit. However, it'd be super important to counsel Miss Daniels on the risk of hypoglycemia when combined with basal insulin.
So we go in, we tell Miss Daniels, hey, we're continuing your metformin. We think that's a great medicine. Going to continue your Ozempic and continue Farxiga. We're actually going to start insulin. What dose are you typically starting patients on?
Well, that's a super great question, Dr. Spencer. I typically start with about 10 units a day for most folks. ADA also says you can start with 0.1 to 0.2 units per kilogram. However, I'll tell patients they can increase by 2 units about every 3 days until their fasting glucose levels are in a target range, typically between 80 to 130. It's important to also counsel them that if they start to become hypoglycemic at any point, they should also reduce that dose by 10 to 20%.
Speaking of hypoglycemia, how are you counseling patients on like signs and symptoms?
Yeah, so this is tricky because a lot of folks will present differently. If they've never felt it before, they might not exactly know what is happening. But I do like to counsel what hypoglycemia might feel like, especially if they've never experienced it. I also encourage them not to skip any meals. It's important to emphasize gradual titration rather than huge jumps in insulin. This is why I counsel by increasing by only 2 units about every 3 days, despite whatever their fasting glucose might be. Also important to emphasize a bedtime snack if they're having those morning lows.
Such practical advice. If you don't mind, I'll probably be stealing this for whenever I'm seeing patients in the clinic. Lastly, when do you need Mrs. Daniels to follow up?
Yeah, so the ADA recommends every 1 to 2 weeks after initiation. However, we know this often isn't practical or feasible for some of our patients in the clinic. Sometimes I'll have patients just message me a blood glucose log in our patient portal. Sometimes I'll just give them a call and we can talk about adjustments this way. At minimum, though, patients probably need to follow up within 2 to 4 weeks to review those those glucose logs together. That way we can adjust doses if we need to and reinforce techniques and talk about hypoglycemia prevention.
That makes sense. Essentially just close follow-up, making sure that that we're avoiding hypoglycemia and we're starting to get those blood sugars within target range. So, Dr. Gribble, this has been a wealth of knowledge. Truly, as Dr. Boers would say, a feast of learning. If you could leave your listeners with 3 practical takeaways from today, what would you be, or what would they be?
Well, it's hard to only pick 3, but I think number 1 would be look for barriers contributing to their hyperglycemia. Is there room for any lifestyle modifications that are practical for each of our patients? Number 2, when starting medications, look at comorbidities as well as side effect profiles. Could class 3 obesity and moderate OSA benefit from tirzepatide, or the type 2 diabetic with HFpEF benefit from Jardiance kind of thing? And then I'd say number 3, when it's time for insulin, make the start simple. And remember, we always need that close follow-up when we're initiating insulin.
Dr. Gribble, thank you for walking us through these real-world diabetes scenarios and for giving us such practical evidence-based guidelines. Today's conversation really reminded me that good diabetes care is about recognizing the story behind the numbers, choosing therapies that truly benefit patients, and knowing when it's time to step up treatment with confidence and compassion. To all of you listening, thank you for joining us, for growing with us, and for the work that you do every day taking care of your patients. This is Health Matters. Thanks for listening, and we'll see you next time.
Health Matters Today is a podcast recorded at Vandalia Health Charleston Area Medical Center Studios in Charleston, West Virginia. Hosted by Dr. Sheylan Spencer, directed by Dr. Amy Bruce, produced by Christopher Cobb and Jason Likens.